Hello, everyone who is just joining us. We're just going to wait a few seconds till everybody enters the webinar here, and then we'll get started with some introductions. At least nobody had to go out in the rain today, so that's a good thing. We're up to about 20 participants so far, so we're in good shape. But I think I'll start with the introductions now, and people can join us as they come in. My name is Leslie Lampton. I'd like to welcome you on behalf of the Ridgefield Library, and to say how wonderful it is again to be working with RVNAhealth as co-sponsors for this program. And the format today is going to be about 30 or 40 minutes of presentations, and then there'll be some time for Q&A. If you have any questions during the program, just type them into the Q&A function, and we'll get to those at the end of the program. So now I am just going to welcome Nancy Rowe, who is the Director of Marketing and Public Relations at RVNAhealth, and she will introduce our speakers this evening. Thank you.
Okay. Thank you, Leslie. Thank you to everybody for joining us, and thank you to Leslie for hosting the evening. This program was originally scheduled for the RVNAhealth Health Fair and Wellness Fair that was scheduled for April. And of course, April was the height of the pandemic, so we of course canceled it, but we decided that the topic was of merit enough that we should present it virtually. So thank you to the library for allowing us to do that. I'd like to introduce tonight our first presenter, who is Dr. John Dunleavy of OrthoConnecticut. And Dr. Dunleavy is not only a hip and knee specialist with OrthoConnecticut, and he is not only an exceptional surgeon who is entirely committed to his patients, but he also was a contestant in the 2018 RVNAhealth Spelling Bee. So we can tell you that Dr. Dunleavy is not only a brilliant surgeon and an excellent physician, he's also a wordsmith and a Renaissance man, and we've enjoyed a nice relationship with him in many ways. So having said that, Dr. Dunleavy.
Thank you so much, Nancy, and thank you to both everyone at RVNAhealth and at the library for putting together this webinar and inviting me. That is true. I was a contestant in the spelling bee, although I'm not sure how much of a wordsmith I was, since I think I was the first one knocked out. Oh. So that could have gone better, I would say. So I've been asked to talk about how does a patient make the decision to say when they're ready to have a joint replacement. And when I say joint replacement, I typically am talking about knee and hip replacements. Those are the ones that I do. But I do think that this will also apply to folks thinking about shoulder or ankle or other types of joint replacement surgery. When someone comes into my office and we sit down and we start having a conversation about their situation, I think of it sort of like there's a checklist, and we have to kind of go down the checklist with the patient to see, well, okay, are they appropriate? First of all, do they have the appropriate problem that we could help them with a joint replacement? And have they tried an appropriate amount of conservative management? That could be something as simple as using some ibuprofen and doing some exercise to adjusting activities, and we'll speak about all of that. The patient has to be medically appropriate. They have to be healthy enough to have such an operation, and not everyone is. Most patients are, certainly, but not everyone is. And then I try to assess how comfortable the patient is, both in terms of how much pain they're having and how much loss of function they have, but also how comfortable are they with the decision, because it is, you know, a decision that you can't come back from. Once you've done the surgery to put metal and plastic and ceramic parts in a knee or a hip, then that cannot be undone. So it's really important that the patient be comfortable with that decision, and also comfortable with their interaction with me and on every level. And I think that's really important. Achieving that comfort level for the patient, I think we have to have this thorough discussion to make sure that they understand what the problem is and what their options are, and then the solutions we have to offer. And in the end, I always explain to them that these surgeries are not surgeries that we undertake lightly, but that ultimately they are elective, meaning that the patient has to make a personal decision about whether or not it's the right move for them. And of course, I'm there to help with that decision making. So the first thing I do is make sure that the patient has the correct problem to make sure that we can really help them. The vast majority of the time, we're dealing with arthritis. And when I say that, I mean degenerative arthritis most of the time, as opposed to rheumatoid arthritis or other types. When a hip or a knee becomes arthritic, even simple common activities can be very painful. Even just walking, getting up into or out of a chair or a car. And in particular with hip problems, it can be difficult to bend down to put on shoes or socks. And it can get difficult climbing stairs, in particular with knee trouble. Sometimes the problem gets so advanced that the joint can bother the patient even while they are at rest. So what are we talking about? What is OA or osteoarthritis? That's the most common form of arthritis, and often referred to as wear and tear arthritis. There are any number of reasons this can happen, but no matter what the cause is, whether it's a genetic or something that occurs because of overuse, the joint will eventually become eroded and uneven and painful because the normal healthy cartilage, which we're all born with, that acts as a cushion, essentially wears away. When that happens, bone spurs will form, and the joint can become deformed as a result. It then loses its ability to move through a full arc of motion, the arc of motion that it once had, the joint. So this is something that can be improved ultimately by doing an operation to put a new joint in and sort of resurface the joint to make the common daily activities that can become very painful less painful. Now, I said there were several causes. It can be from excessive wear. There can have been injuries involved, such as high impact activity that's repetitive. Also, this is not a disease of the young. I have to say it is affecting more and more people in their 40s and 50s these days. But it tends to occur as we age, but not in everyone, and certainly not in everyone to the same extent. It does tend to occur more in heavier patients, and it can also come from activities related to work or even accidents that will eventually cause the joint and the bones around the joint to deform. So we start out always with non-surgical options. What are we talking about? Some are extremely simple, like modifying a person's lifestyle somewhat. An example of that would be if a patient is having a lot of difficulty with fairly aggressive activities, such as running, where moving to a low impact or non-impact type of exercise, such as biking or swimming, might really make the difference and may get that patient to a point where they're comfortable enough with their joint that they don't feel they need an operation. Bringing down a patient's weight, or certainly keeping in good shape, is also very important, and physical therapy may be helpful. So I will tend to write a physical therapy prescription for almost everyone. A lot of times patients are able to do exercise on their own, and simple things such as yoga and stretching and walking can be adequate for some people. simple medicine like ibuprofen and Aleve, which is anti-inflammatory medicine that's non-steroidal, and you can take right over the counter, sometimes can be very effective, and it's certainly reasonable to try that. Once that loses its efficacy to a certain degree, especially if a patient has a significant flare-up of pain in a knee or hip joint, we can try an injection. Typically, we start out with a steroid injection, such as cortisone. That's very common. I do anywhere from 5 to 10 of those a day, believe it or not, in my office. And then slightly less common, but still something that we might try are what are called hyaluronic acid injections, which is sort of a cushioning type of injection of a synthetic substance that the natural substance of which we all have in our joint fluid. And the synthetic version is made, believe it or not, from chickens. And we inject that into knee joints quite frequently. It's not approved for hips, and its ability to help knee arthritis is somewhat in question, but it's something to talk about, certainly. Exercise and weight control are critical. It's been shown that exercise and keeping one's weight under control is some of the best ways to treat this kind of problem. Exercise will decrease pain and will improve someone's flexibility. And keeping to a healthy diet can certainly facilitate losing weight and keeping a person's weight under control, and then therefore putting less stress on your joints. We already mentioned some of the medicines. People also try Tylenol, and I highlighted narcotics here. Narcotics are highlighted because that's really not something that we would typically use to treat arthritic joints. I think if you get to a point where you're needing narcotic pain medicine to treat your pain, you really should seriously consider surgery at that stage. There are some effective topical pain relieving creams and sprays, such as something known as Voltaren gel. And I've heard patients even say that some of the CBD creams can be very effective, and I think that's reasonable. Okay, so patient then says to me, okay, you know, Dr. Dunleavy, I've tried everything. It's not working, or it's not working well enough. Now, what do I do at this point? So the basic question for a patient to ask is, am I satisfied with where I am? Am I satisfied with how my knee or my hip feels and my level of function? And if the answer is no, they're not satisfied, then we start talking about surgical options. Hip replacements, we'll start there, and I'll go through these slides fairly quickly. Hip replacements have been around for a while now, first performed in 1960, and I agree with the statement from the American Academy of Orthopedic Surgeons that a hip replacement has been one of the most important surgical advances of the previous century. There have been many improvements, even in just the last few years, in design and techniques, which I'll touch on. And these days, hip replacements are more effective and they last longer. And I think it's fair to say that the surgery is a little easier on patients to tolerate than it used to be. And it's a huge number of these done every year. I'm not sure if that 400,000 number is even accurate. I think it may be higher than that. So what should a person expect? Well, they should expect a dramatic reduction in pain. And that's not an exaggeration. It should be impressive and immediate, the reduction in pain, and an improvement in their ability to perform common activities. So patients will often ask, well, what can I do and what can't I do? What do I have to avoid? And this is kind of a fun slide. That's on the left of the screen. That's the first President Bush jumping out of an airplane. I believe it was for his 80th birthday, and he had already had at least one of his hips replaced. So I kind of had that up there as a joke because one of the things you would say to avoid would be high impact activities like jumping out of an airplane, for instance, or a contact sport. But, you know, what can you still do? You can almost do everything. I mean, there's very little that a person really can't do. Patients that I have, they ski, they bike, they even run, although that sometimes can be difficult. These days, I think it's reasonable to say that a hip replacement should last about 25, 30 years. And that has to do with that improvement compared to years gone by, when more than 10 years ago, the answer to that question probably would have been about 15 years or so, 10 years. There have been improvements, in particular in the piece of plastic that's put in. Ultra high molecular weight polyethylene is the plastic that goes in there, not in every case, but in most cases. And it's been engineered to a point where now it's lasting a very long time. So we're not really sure how long they'll last, but they should last a very long time. The surgery, there are different techniques involved. First of all, there are total replacements, there are partial replacements, there are other things with a hip called hip resurfacing surgeries, and there are different techniques such as minimally invasive surgery. Total hip replacement refers to a surgery where the entire hip joint, ball and socket, are being redone. So you'll see here what the implants look like. There's a metal stem there that is inserted into the upper part of the thigh bone, which is called the femur. And there's a metal socket piece that's inserted into the opening in the pelvis, which is for the socket opening, called the acetabulum. And then there's typically a piece of plastic that's placed inside that socket piece, and then that ball piece that is either made out of usually metal, or more commonly these days, a ceramic substance. And when you put it all together and you take an x-ray, it looks sort of like that. This is not something that can be done through arthroscopic surgery, but this slide shows that a minimally invasive approach has changed the size of the incision dramatically over the course of even just the last maybe 10 years. The instruments have been improved, and we are now able to do the surgery through a fairly small incision that would be outlined by that blue line you see. It is important to point out, though, that the incision will be as big as it needs to be so that we can accomplish the surgery safely, and of course as small as it can be. It is possible that these smaller incisions will make the rehabilitation slightly shorter than they once were, but it should be pointed out that the minimally invasive surgery has not been proven to show improved overall outcomes eventually. I always say this: if I could do hip replacements all day, I would. And the reason I say that is because when asked after 4 years how satisfied they were, patients said that they were very satisfied and would have surgery again if they had it to do over again at a huge rate, about 96% of them, which is just incredible. And Regis Philbin, the late Regis Philbin, is on there because he was one of those very satisfied patients. Unfortunately, knee replacements are not quite as well tolerated. They tend to be more difficult for patients, and I think that has to do with the complexity of the joint. So basically, you're resurfacing an arthritic knee joint with metal and plastic pieces, as would be depicted by this slide. Sometimes the term total knee replacement can give patients the wrong idea. Sometimes they think you're going to cut out their whole knee, but actually you're not. You're going to resurface it with those pieces so they don't have bone rubbing against bone anymore. There have been some advances. There's what's called patient-specific knee replacement, where the patient will get an MRI beforehand, and these cutting guides that are depicted in the cartoon are made for their unique anatomy to help us during the surgery. And that allows the surgery to be done through a smaller incision with less trauma, and hopefully then less pain and a quicker recovery. And also the minimally invasive technique depicted here that avoids cutting into the tendon above the kneecap. That's also something that can speed up the recovery. And this is, at this point, something I do on just about every single knee replacement. Partial knee replacements are knee replacements that only resurface one element of the knee. There are basically 3 different parts of the knee that we talk about: the inner part and the outer, and then under the kneecap. And this has been increasing in popularity. There's less surgery involved, And the patients after these surgeries, when it's appropriate, will tell you that their knee feels more like a normal knee than a total knee replacement knee, because you haven't removed any ligaments where you would have to remove ligaments in a total knee replacement. These are those three parts of the knee, and these are some x-rays depicting how any of those parts can be resurfaced individually. We're using robots quite frequently, and this, I think, now brings us to the most up-to-date modern sort of technology that's out there. This technology, I believe, is here to stay, and what the robotic technology does is it allows those pieces that I just showed you the pictures of to be placed in the knee or the hip with more accuracy than in the past, and to help with balancing of knee and hip joints to a much higher degree than we used to be able to do. And I do think that this will make a significant difference, in how patients will do and how their joints function. At this point, it's not possible to say what that importance is because it just hasn't been out long enough. But early studies showing the outcomes of robotic-assisted surgery are very impressive so far. And so we've just, my group has just invested, and we just got one of these robots for our surgery center where we can perform what's called Makoplasty, and that's because the robot is called a Mako robot. And without getting too bogged down into the details, essentially the robot allows us to plan exactly where we want those pieces to go before we start operating, and it then allows us to remove just enough bone to facilitate that surgery and make it come out in the best possible way. That's what the arm of the robot looks like. It's important to point out the robot does not operate on people. I operate on people. The robot is just a tool, but it is a very effective tool, and it helps us both with knee and hip replacements. This is a cartoon depiction of how the robotic arm is used to help us during a hip replacement to place the pieces more accurately. So these days, after surgery, the patient will be sent to the recovery area and they start physical therapy straight away. Now, in the past, when we were doing these more in the hospital, they'd be there anywhere from 1 to 3 days. And I certainly still do a significant portion of the surgeries at the hospital, but we've gone to doing more and more outpatient joint replacement where there's no need to go to the hospital at all. And we use the same surgical techniques, but in our surgery center setting. And I think that the advance that sort of has allowed us to do this more than anything, more than the minimally invasive techniques, more than the robot, really has to do with the anesthesia and the impressive advances of anesthesia that have occurred really in just the last 2 or 3 years. They are now able to get patients to a point where they have a low enough degree of pain where they can get up immediately. And I mean like in the recovery room and walk around. At our surgery center, patients will have the surgery, recover right there in the surgery center. And after about 4 or 5 hours or so, on average, they get in the car and they go home. And our partners at RVNAhealth have been so helpful in helping us rehab these patients, where they come out to the patient's house a lot of times before surgery and certainly the same day and after surgery to check on them, to make sure they're doing well and to help them start their rehabilitation. We do have now a capability of keeping patients overnight for 23 hours if it's appropriate. But I have to say, I think most patients will just go home that same day. So this is really, the most up-to-date sort of technique that we're using, and I'm really excited about it because I think this is the future of joint replacement. This slide shows the growth of our program. We started doing just a smattering of joint replacements as an outpatient case back in 2015, and we've steadily increased ever since. And here we are in 2020, already up to just about 100 cases. And that, keep in mind that that is having had a several month period where we did none because of the pandemic. With that, I will stop talking and I will stop sharing my screen, and I will invite Gigi Weiss of RVNAhealth to come in and speak to us about some of the rehabilitation elements involved with getting over a joint replacement.
Okay. Thank you, Dr. Dunleavy. I appreciate it. Let me just get to where I'm going here. All right, that's mine. And then do this screen. Share from the beginning. Okay. Thanks again, Dr. Dunleavy. We're really excited to be a part of this, and thanks to the library for allowing us to show you how we can help you with everything. So knowing when to say when. So a lot of what Dr. Dunleavy went over, I'm just going to kind of reiterate because we see this all the time. The existence of chronic pain in the joint. And as he said, you're regularly taking painkillers to deal with the pain. The pain keeps you up at night, despite use of just general medications. The pain is difficult when you're just walking or bending over. It really doesn't have any relief when you're during rest or at night. The other thing is doing regular tasks, just like putting on your socks, putting on your shoes, getting up from a chair, going up and down stairs is usually a big indicator that there's issues that you need to deal with. As far as some balance, you're having some balance issues standing on one leg. Other things is just general stiffness. If you're feeling stiffness in the joint, the knee or the hip isn't moving like it used to, you are not able to get in that chair as easily. So all those kind of daily things you're just kind of feeling in the joint. And sometimes you just feel emotionally worn down. You don't, and when you're starting to feel that way, where it's really affecting your sleep and affecting you emotionally, you might be getting closer to saying when. So some pre-surgical options that we're discussing is, general exercise, like we said, just it has great benefits, of course. A directed physical therapy also may be able to prolong the need for surgery. A lot of times with the physical therapy, it actually, we get to a point where the therapy is not able to help, and that's when we say, you know what, this is the time to go back to your surgeon and let him do his thing. So the good thing is if you have had therapy prior to your surgery, there is studies that show that the recovery is much less, 29% less, that there's a significant cost savings because of the recovery is less. So, there's a shortened time. So the therapy is beneficial to keep you going for a little bit longer. And also if you eventually do have surgery, it helps with your recovery. So knowing when to say when. So even after you've tried all these non-surgical options, and you're still in pain, you're still up at night, and you're having the strain and stress on the joint, you're still in pain. So you may need surgery. So that's where we can help at RVNAhealth. We partner with the doctors, and once Dr. Dunleavy or anyone else in the practice determines that you need the surgery, we have a nice seamless intake process where they send us the referral. And a lot of times patients are worried about what happens after surgery. So what we do is we do an on-site home safety eval. So especially for those same day surgeries, we absolutely go out to the patient's home. We do a full evaluation. It's done by a PT or an OT. We determine, see the stairs, we see how you're entering the home, where you're sleeping, where your bathroom is, where your kitchen is, what chairs you'll be sitting on, where you should sit, where you shouldn't sit. So we kind of go through this whole process with the patient so that they feel safe and they feel comfortable and more relaxed about coming home directly. So we do that for all of the on-site on same-day surgeries. We also, a lot of times, as Dr. Dunleavy mentioned, they do the surgeries in the hospital. With those, we do a phone assessment, determine whether we will need to do an on-site assessment, and we ask those questions. Who you're going home with, what car, because the hospital stay is now generally, between 1 day, an overnight to 2 days. And again, we just kind of assess and ask questions and determine if we need to do an on-site eval, and if we do, then we will absolutely go out and do an on-site eval with the patient and assure them that they're safe and comfortable to go home. So post-surgical care, the old days was short-term rehab, so just kind of going through, kind of the differences. In the past, you go from hospital to short-term rehab to home care to outpatient, but now we're kind of tending towards the home care. So short-term rehab is very expensive. It's a high risk of infection, a higher risk, I should say, of infection. You're more exposed to the community. It does have the 24-hour support there. There is 24-hour medical oversight at short-term rehab. And sometimes people need that, or the family needs a respite stay. So those are one of the reasons why people had chosen to go to short-term rehab. But of course, home health is much less expensive, much more low risk of infection. Limited community exposure. People love to recover in their own bed, in their own home, which is important. There's this family support, and then you also have the home health support, and then the outcomes that we've found over the last 5 years are the exact same, if not better, when people are recovering in their own home. And of course, these days there's a less COVID risk. So the home health tends to be much more where we're leading, and we found that the outcomes are the same. So home health care, if you do need the surgery, the nurse, as Dr. Dunleavy explained, the surgery is done that morning. Our nurse will meet the patient in that afternoon. Usually, they go home about 2, 3, 4 o'clock. Our nurses are there within the hour of arriving home if you have it done at the surgical center. If surgery is done at the hospital, sometimes they don't need the nurses, so just the therapist will come the next day. So in both cases, the therapist will be there the next day after coming home. And when you're home, you're pretty much seen every day by therapy. Nurse will be in within the first week, probably 1 or 2 times, but pretty much therapy is there for every day, depending on the situation, but from 1 day to 2 weeks post-surgery. We usually plan for discharge from home health into an outpatient. Sometimes patients are ready to go within 4 days. Sometimes patients need more therapy. We have some patients that actually go right from the surgical center right to outpatient therapy. So it all depends on the patient, but it's typically within 2 weeks, patients are out of their homes and ready to go. And also the nice thing about home health is we also have a service occupational therapy, and that's where they will help you with other needs. So kind of the differences between physical therapy and occupational therapy. Physical therapy works on your strength, works on your range of motion, works on your walking, your gait, your balance, your mobility. We help with the home safety. We help with pain management in your home. We help with the edema control. So we're really there for that, the therapists as well as the nurses. And the occupational therapy, a lot of them for the total hips, they need to work on giving you sock aids and shoehorns because of some of the hip, more of the hip precautions. They work on everyday things, getting you back to cooking, getting you back to cleaning, all those fun things that we don't want to do, and bathing. So the occupational therapist can help with that. And then once you're ready with your discharge and you're ready to go, the next step, what's the next step? We go dancing. But no, the next step is going to outpatient therapy. So like I said, within 4 days to 2 weeks, you're ready to go to outpatient therapy. We have a therapy center right here at our 27 Governor Street. It's the Rehabilitation and Wellness Center. So we're able to make a smooth transition, but you can go to whichever outpatient center that you would like. But typically in many outpatient centers, you do strengthening, the same things that you do in the home, but you just kind of do it a little bit more intense in the outpatient center. You're working on range of motion, which is very important, working on your gait, work on your balance, your stretching, manual therapy modalities, which can consist of heat, cold, kinesiotaping. We work on a home exercise program, so to continue what you've learned in your home care, you can do an outpatient, and then we kind of step it up and add more to that. The exercises are so important, especially with the total knee replacement, that it continues. You want to keep that mobility and range of motion going. And typically with outpatient, again, you're there 2 to 3 times a week, anywhere from 4 to 6 weeks. Some are longer, some are shorter, but that's kind of the general things. We can also do in the time of the pandemic, we're able to do telehealth visits, which are really nice, so we can kind of guide you through exercises. We could also do that in home care as well, which kind of helps guide you through exercises. And I think that was it. So.
That's wonderful. Well, we do have quite a few questions here, so I don't know whether Dr. Dunleavy wants to turn on his video again and we can bring him back to the presentation. So there's one for you here, Gigi. What type of exercises are good for knee problems in particular?
That's a loaded question. Again, anything that if they're having pain with weight bearing, you have to be careful with doing weight bearing exercises. So if you're having issues, you could do non-weight bearing things, even like swimming is great for someone that if it's a truly arthritic issue. But you can, if you have any questions specifically, you could always email me and I can answer them. But there's a lot of open chain exercises. There's a lot of things that we can direct you, but we really need to kind of figure out what's causing the pain, and that way we can like direct your exercises. So I can't just give you a general idea.
Okay, great, thank you. And do you know how long a shoulder replacement might last? Someone has a question here.
I don't do shoulder replacements. I'll just start by saying that, but I am somewhat familiar, and I think that they're intended probably to last in the order of about 15, 20 years. I don't know that the data is quite the same as for hip and knee replacements, but if somebody asked me that in my office, I would refer them to one of my partners who perform that operation. The thing is, those tend to be done a lot of times in really elderly folks for, after they've broken a shoulder or really developed terrible arthritis. So I think the answer is probably that it's probably about 15 years or so is a reasonable thing to say. Mm-hmm.
Okay, thank you. When choosing a surgeon for hip replacement, what criteria should we ask to determine that the surgeon is the right choice?
Yeah, I mean, I think the first thing is you want to make sure you have someone who does it for a living, that doesn't just sort of dabble in it, because, and when I say dabble, I mean, does fewer than maybe 40 a year, because there are a lot of doctors out there, orthopedic surgeons, who do joint replacements, but it isn't necessarily their specific niche. And one way of finding out if a particular doctor, is certainly to ask them how many they do a year. I think you'd be looking for at least 50 minimum. But also you can look for someone who is board certified, and specifically someone who has done what's called a fellowship in joint replacement. And also you'll see it referred to as a reconstructive surgery or adult reconstruction. So for instance, in Danbury, I'm one of 3 doctors who does have those sort of qualifications. But that would be a good way of starting. And then of course you want to sit there with that doctor and make sure you're comfortable and you have a good rapport, because that's actually also very important.
Okay, great. And how long is a hip replacement surgery?
Most of them about an hour and 15 minutes.
Wow. Amazing. And Dr. Dunleavy, can you talk a bit more about medical appropriateness of candidates, in particular for knee surgery? Are there BMI constraints, for example, or if someone has heart issues, would that be an issue?
Yeah, so yes, not everyone is appropriate. There are constraints, and constraints involving ongoing medical conditions, especially conditions involving the heart and the lungs, would be the most worrisome. And so you do need to obtain medical clearance, typically from your primary provider, before we would be able to proceed. And I refer to that as the light turning green. We can't go forward with the surgery until we're sure that it's reasonably safe from a medical point of view. But the 2 criteria that I would point out, BMI, or body mass index, is something as it increases, and that would increase with people getting either shorter or heavier, or a combination of the 2. There is an added risk as that number increases. So there are certain surgeons who will simply refuse to operate on patients above a certain point. And I think that's a little bit controversial, to be honest. I think that every case should be looked at individually, and that's how I do it. But not everyone will do that. And the only other one I'd like to mention is in folks who are diabetic in particular, having an appropriate level of what's called the hemoglobin A1C, which is a blood test that's done to measure how well or how poorly controlled the diabetes is. That number needs to be low enough where we would consider it safe. In other words, certainly anything less than a 7 would be good, but anything above an 8 would not be acceptable. We just simply can't proceed in that scenario. So those would be the ones I would mention at this point, but there are more.
Okay, thank you. And what is the decision process by the surgeon to determine partial or full hip replacement?
Yeah, so partial hip replacement is done almost exclusively in a scenario where someone has just fractured their hip, which is, not something that, is going to be handled in an outpatient setting. That's going to be somebody, falls, unfortunately breaks their hip, and requires a hip replacement to handle that problem. And for somebody, again, usually very elderly and not particularly high functioning, and I'm at this point, I'm usually just doing that for people beyond the age of 85 years old or with significant dementia who've broken hip. You would not do that to treat degenerative arthritis. Those would all be hip replacements, total hip replacements.
Okay, and I think you've answered this one before, but how often would the surgeon have to perform surgery again after already replacing a joint?
Yeah, the rate of revision. Well, I think, it certainly happens. It's rare enough. And I think that the overall rate of revisions will probably increase. And the reason for that is so many of these joints are being done, and eventually they will wear out. So especially these days when patients are having these surgeries done in their 40s and 50s, you know, I am telling the patient to be prepared that they will need a revision at some point. They likely will need a revision at some point. They may not. I think in my practice, I would say my practice, probably about 10% of my practice are revision surgeries only. The busiest revision doctor I ever heard of was someone who focused his practice on doing these things, and he did about 80%, but he was someone at a major academic center who patients were referred into. So it's still, you know, the minority of the surgeries that we do. I don't know if Gigi has any experience, you know, with seeing revision patients, or how often, you know, the RVNA sees those patients.
Yeah, we don't see a ton of them either. Probably 1 or 2 every 6 months.
Yeah.
Okay, and does waiting for surgery while participating in alternatives like injections and therapy cause any further degradation of the hip joint?
Well, the answer is technically yes, because every step you take, there's some degree of degradation that happens. But I always tell patients that you're not going to really burn bridges, so to speak, until you start to notice a loss of motion. And that's usually a pretty good indication that it's time to you know, pull the trigger and do something. And the other sort of helpful symptom, I suppose, or if a patient starts to become unsteady on their feet and is at risk for falling down, then that's the closest outcome to telling them they really should do the surgery. Very careful to tell patients, you know, this is elective, this is your decision. But once that starts to happen and they're at risk for hurting themselves, then, you know, they should think about it carefully.
And you know, sometimes patients come to the clinic hoping to get therapy, and like we said, it will prolong it. But a lot of times we help them make the decision, because once they've had the course of therapy and we see that they're not improving or that they're still having the same pain, that's when we refer them back to the physician and say, I think it's time, you know. And a lot of times they're happy to hear that we're all in agreement, because they try to prolong to a certain, you know, they want to wait another month or 2 or even 6 months, but at some point it comes to where we always say to the patient, you'll know when, because you can't sleep, or you can't, you know, a lot of people get to that point and it might be a little bit too late. So we try to encourage before they really get to, like what Dr. Dunleavy said, before they really lose that range of motion.
Okay, great. And what type of complications can occur from hip replacement surgery?
There are many. The most concerning typically is an infection occurring. Infection is just a disaster when that happens. You know, we have means for dealing with it, but in all honesty, it really is a disaster. It's awful when that happens. So we're, you know, pleased that the infection rate is very low. It's somewhere in the neighborhood of 1%. And one of the reasons, as Gigi mentioned, to seriously consider, if possible, outpatient and also outpatient surgery, and avoiding nursing facilities if we can, because I think it is reasonable to say there'd be a lower risk of that, although not zero. And also with hip replacements, you will worry about the bone, one of the bones breaking, a fracture occurring, or the ball and socket joint potentially popping out of the socket, which is known as dislocation when that happens. And those can all happen, but honestly, the worst is the infection happening.
Okay, great. And thoughts on a double total knee replacement?
Yeah, I'm going to ask Gigi to chime in on this in a second. I'm not a big fan of it. I've done it several times, many times. I try to discourage patients from it just because it's very difficult, in my experience, it's been very difficult for patients to do the rehabilitation effectively. And that's the reason. It usually is reasonably safe if somebody is healthy enough, but they just have such a hard time with the rehab that I discourage it. So I don't know what Gigi thinks about that.
Yeah, the rehab is definitely harder because I think what we found, a lot of times patients choose to do the double knee or because they feel like once they won't go back. But actually that's not the case. That's in what they think in their head. We've some patients that need both knees done. I think it's actually more successful when they do it like a month or two apart. Like they have the one knee done and then they kind of get their rehab and then that's their good knee and then they go back and they get the other knee done. So it seems like that seems to be the most successful when you actually need both of them done right away. I don't know if you find that too.
Yeah, I'll just sort of as a follow-up, I agree with that. That's why I had somebody just today who we did a knee 6 weeks ago, and now she wants the other one. And because she's doing well enough with the first one, we're going to go ahead and do the second one. Yes, it's 2 trips to the operating room, whereas both together is just one. And certainly that is a real benefit to just have to go once, but not if it means it's going to be that much tougher on someone. So that's why I discourage it. But, it is done. It is fairly common, actually.
Okay, great. And someone is asking, do you operate from the front of the leg?
They're probably talking about hips. So,
Yes.
Yep, there are several different approaches to a hip replacement. There's some from the front, from the side, from the back. I do all of them. Although I would say I most often will do what's called a mini posterolateral approach. That's the approach that I've found is sort of most user-friendly, especially with the robotic technology that we've now really adopted. But there are upsides and negative aspects to each and every one of those approaches. And at the end of the day, whether we do it anterior or through one of the other techniques, the pieces that go in end up in the same place. And there isn't any long-term difference. There are short-term differences. So I suppose the short answer is yes, but not as much as some of the other techniques.
Okay, and I think you touched on this before, but someone is asking for a younger patient requiring a hip replacement in their 40s or 50s, say, who would likely need a second replacement in their lifetime. Can you speak a little more about this issue, how successful they are and how to navigate this?
Oh yeah, I mean, I wouldn't, I certainly wouldn't tell the patient, that, oh, you need to wait longer because you're too young. I mean, if they need it at that point in their life, then they need it. And then if the day comes, not when, but if the day comes when a revision procedure is necessary, then there's every reason to think that procedure would be very successful. We do them all the time, and they are a little more difficult in many cases. But no, I wouldn't discourage the patient from moving forward, because their problem is most relevant right now, and they need to. They need to deal with the problem in front of them now, and we sort of will cross that bridge if and when we come to it.
Okay, great. And is there a limit to how old one can be to get hip surgery?
Not that I've encountered, no. So the oldest patient I've done a hip replacement for was, I believe, 105.
Wow.
Now that was, I'll grant you, that was not elective. That was, she fell and broke her hip. But, she did fine. After that, she did pretty well, actually. The oldest elective patient, I believe, was 97, I want to say, 97. And it was because she could no longer remain independent the way she wanted. And she simply, it's actually a really good example of somebody saying to me, doctor, I just am not okay the way I am. I understand, she said to me, I understand there are risks, and I feel like I don't want to live this way. I want the surgery. And we did it, and luckily she did very well. but there isn't really an upper age limit, I suppose.
Yeah, okay. Is there ever a time when it's too late and you cannot have hip or knee surgery if you have nearly complete loss of range of motion?
Well, there's never a situation where you can't do it. Sometimes it can be so severe that it's much more difficult both to do the surgery and also the rehabilitation afterwards is much more difficult. So this is kind of where Gigi and I were saying that, you know, you don't want to wait till you lose that range of motion, because even though we may go and replace the joint, all of the surrounding tissues, the muscles, the tendons, and everything will now have gotten used to the situation where the joint doesn't move. And so it takes a long time for them to sort of adjust to the new normal. And it can make it much more difficult for patients.
Yeah, if you have the surgery, you definitely want to go in as strong as you can go in. And it makes the rehab much better, much easier, and with everything.
Okay, and I think we have time for one question here. So how much damage can occur with a good joint if you know that you will need surgery eventually?
Oh, I see what they're asking. I think you will tend to overload the opposite side. That's natural. And a lot of times the degenerative change will be bilateral to a certain extent. Usually one knee or one hip is a little farther along than the other. So I would say that, you know, I would usually tell patients, okay, so your left knee is a 9 on a scale of 1 to 10, where 10 is the worst, and the other knee is a 5. So it's probably, you know, a few years behind, but we may get there eventually, just to give them an idea. But it's certainly very common for the other joint to eventually wear down also.
And with the therapy with someone in that case, you know, a lot of times then we call the operated knee the good knee, because they tend to get so strong on their new knee that's now their good knee, and then it helps alleviate some of the strain from their opposite knee.
Okay, wonderful. Well, that's all the questions that we have. Is there anything else you guys want to add before we end here this evening?
I appreciate the invitation.
Yep, thank you.
Wonderful, and thank you everyone for taking part in the webinar, and I'm sure you got a lot out of it. So thank you, and goodbye everyone.
Okay.
Good night.
Thanks.
Good night.